Now for our program. Brian is a proud member of the class of 1990 and practiced cardiology in Asheville for 20 years before leaving his practice in 2020 to focus more on lifestyle medicine. He was then chief medical officer for a healthcare startup company out of Austin, Texas called Love Life, and is currently serving as the medical director for the Mission Hospital Cardiac Rehabilitation Program in Asheville, in addition to working on several lifestyle-related projects. I am thrilled to turn this program over to Brian.
So thank you so much for the kind introduction. And thank all of you for being here tonight. It's apparently a slow night for Davidson grads across the country. So I'm going to tell you more about my story in a minute, but I'd like this title, Let's All Die Young as Late as Possible. A mentor of mine shared that with me about maybe 12 years ago. And I thought we could maybe spend an hour tonight talking about some of the behaviors, lifestyle behaviors that might improve the odds of that happening. Sadly, Hans, my mentor, died of an AFib-related stroke about 1.5 years ago. So this is a curve that many of you, I'm sure, are familiar with. And by the way, this is a sort of a 101 level course. For some of you, this might be, some of it might be review. For others, it won't be. I felt it best to start at a level where we could all build from that. In the Q&A, for those of you who have already done a deep dive in lifestyle medicine and longevity, we can certainly go to upper level courses level if you'd like. So if you look at health on the vertical axis and age on the horizontal axis, the average population lifespan looks something like this. The last decade of your life is typically spent in the United States in declining health. And for those of you who are Peter Attia fans, you're familiar with this idea of what he calls the marginal decade. The average lifespan for men in the United States today is about 75, and for women is actually 80. But you can see that after about my age, it tends to start to tail off for so many people. Really, what we want to do is focus more on our health span than lifespan. Health span is living with adding years to life and adding life to years, compressing that morbidity, reducing that marginal decade and slowing that decline so that we're living at a healthier level and then tailing off sometime around, hopefully a little bit later, but more important, we want to be living better in the time that we have. I like this quote that your health isn't everything, but without your health, everything is nothing. I'm really not sure who said that. And it's not just physical health that I'm talking about here, but mental, emotional, and spiritual health, holistic well-being that really moves us from surviving to thriving. I want to show you a video. This is the video. Tell me if you can hear that, okay?
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide. The average Canadian will spend their last 10 years in sickness. Change your future at makehealthlast.ca.
So as Judith said, I've been a cardiologist in Asheville since 2001, and it's been great fun. I enjoyed cardiology. I wasn't looking for something else. Something else found me. I really enjoyed taking care of all my patients. But there was this nagging feeling that everything that I'd learned in medical school and felt in residency and fellowship was really just not enough. The patients that we stented in 2001 were coming back in 2004 and we're getting a second stent. In 2008, maybe they come back with another event and end up with a bypass surgery. 2012, a stent of a bypass graft. And I felt like I was doing all the right things. They were on all the right stuff. I was managing their cholesterol, their blood pressure, their diabetes, their cardiovascular disease aggressively. And of course, there was a selection bias. I wasn't seeing the ones who were doing well. I recognize that, but I was seeing, I was super busy, inundated with patients, a 3-month wait list. And there was just a feeling that I just wasn't, what is missing from this equation? A little growing dissatisfaction with the status quo. And as fate would have it, I saw a patient in 2013, maybe 14, named George. And George, it was about 65, spent part of the year in Cleveland, Ohio, and part of the year in Western North Carolina. George had had 2 bypass surgeries, 2 different open heart procedures. And when he came to see me, he came for a second opinion, which was really interesting because he had gone to a world-renowned cardiology clinic in Cleveland, Ohio, for an opinion on what to do with the fact that he was having daily angina, exertional chest pain. He was taking nitroglycerin on a daily basis, very dissatisfied with his health span. And he said, "What do you think I should do?" And asked me if I'd ever had a patient who had had a 3rd open heart surgery. And I had had 2 at that point that had had 2 or 3rd open heart surgery, 3-peat. And he asked me, of course, next, how are they doing? And I said, I'm sorry to tell you that they're both deceased. They had relief of their symptoms for 4 or 5 years, but at that point, they had used up all their bypasses. We take radial arteries, we take walls, arteries from the chest wall, we take veins from the leg, and we plug them into the aorta and literally bypass the blockage. And so, after you've had a 4-vessel and a 5-vessel, you've really used up all of your conduits, we call them, all of your bypass tubes. So the 3rd bypass surgery, we end up using cadaver grafts, and it's not your tissue. And so there's a little bit of a rejection process. So I told him that you could expect that he would have some improvement in his symptoms, but I don't think this was a panacea. I mean, we've done this twice. What makes us think that the 3rd time in using someone else's tissues is going to be the answer? So I happen to have a book in my office called Prevent and Reverse Heart Disease by Dr. Caldwell Esselstyn. And I gave it to George and I said, let's see how you do. I mean, this espoused a very strict dietary change from the standard American diet, SAD, to a whole food plant-based diet with no added oil. So really big change. And I said, George, if your symptoms get worse, we can handle an urgency and emergency. But if you're stable, let's see how you do, and let me see you back in 3 months. So he came back 3 months later, and I was blown away. I actually forgot about him. But when I saw him walk in the office, I could barely recognize him. He looked like a completely different person. So he walked in the exam room. I walked right in behind him, and he said, Brian, I think you've changed my life. And I said, I'm eager to hear more. I've lost 27 pounds in 3 months, which was great, but not the goal. He said, my cholesterol's dropped 100 points, 100 milligrams per deciliter. And at that time, I was also a board certified lipidologist. So I was a cholesterol expert, in quotes. I'd never seen anything like that. I stopped one of his cholesterol medicines and reduced his other cholesterol medicine by about 75%. But the thing that blew me away, both of us away, is he said, within a week of changing my diet, I have not used a single nitroglycerin pill in 3 months, and I'm walking on a treadmill at 30 minutes a day at certain speed and certain incline. I don't remember the details of that, but that was a real wake-up moment for me, for both of us. And I had all kinds of questions. Is this representative of what happens when somebody changes the way they eat? What is the mechanism of action? How did I not know this? What does this mean for my career? Just a lot of questions. So that's how it started. I became very interested in plant-based nutrition which got me then interested in lifestyle medicine. And I started facilitating lifestyle medicine courses after work a couple days a week. And for the first time in my professional career, I had people saying, "This is the best I've ever felt. And why has my doctor never told me this before?" And it was very different from the energy that I was experiencing in my cardiology practice, which was not, "This is the best I've ever felt." It was, I feel not great with all these medications, and is there a better way? So that ultimately led me to leave cardiology and become the medical director for the cardiac rehab program and get interested in lifestyle medicine. So these statistics are not surprising, I don't think, to anyone on the call. These are the most common causes of death from the Centers for Disease Control in 2023. Heart disease is number one. It's been number one for decades. Cancer is a close second. Note that a lot of these other diseases on this list are lifestyle related. Alzheimer's disease, currently number, 6, has increased in incidence by about 90% since the year 2000. Something interesting is going on there. This always reminds me of this Indian fable of the blind man and the elephant. I feel like this is representative of the current medical system. The 6 blind men were asked to describe an elephant, and someone grabs the ear and says the elephant's like a fan. Someone grabs the tail and says the elephant's like a rope. Someone grabs the trunk and says the elephant's like a serpent. No one's really looking at the big picture. And I feel like that's what we have in our current medical system. We have cardiologists treating chronic diseases with statins and stents. We have oncologists treating it with chemotherapy. We have endocrinologists using insulin and now GLP-1s. No one's really looking at the big picture, and this is very much a Band-Aid type approach. It is very expensive, it is inefficient, and it's ineffective when it comes to treating chronic disease. Today, the whole system is really founded on pills and procedures. In 1990, when I graduated from Davidson, we spent about $40 billion on prescription medications. In 2021, which is the last data that I've seen, we spent $571 billion on prescription medications. It is incredibly expensive. We have the most expensive healthcare system in the world by a long shot. Our results are certainly not commensurate with the level of spending. It is incredibly inefficient, and frankly, it's ineffective when it comes to treating chronic diseases. In fact, there were about 175,000 fatal adverse drug reactions reported to the FDA from the NIH in 2022, which, if you go back to the previous slide, that would put adverse drug reactions as the 3rd leading cause of death in the country. So that system needs an overhaul. This is what I really think it should look like. I'm not saying that there's not a role for pills and procedures. I'm saying that it makes no sense as the foundation of a medical system. Lifestyle is both the cause and the cure of most of our chronic diseases. We're very good at treating acute diseases. We're very good at treating trauma, infectious diseases. We stink at treating chronic diseases, and we need to help people make changes in how they live. Natural therapies that restore healthy physiology would be sort of that second tier. My older son now is in physical therapy school, and physical therapy would fit in here very nicely. And pills and procedures at the top. Lifestyle medicine is an old concept, but it's a new thing in American medical care. It is defined as the evidence-based practice of helping individuals and families adopt and sustain healthy behaviors that affect their quality of life. And I have bolded evidence-based because it has to be evidence-based. It can't just be a good idea. We have to have statistics and studies that show that this actually works. And it really is about healthy behaviors. There's an educational component. Sometimes we just don't know what we don't know, but it really is about integrating what we've learned into meaningful behavior change. And then the third leg of that stool, not represented here, would be the community support piece, which is really my primary interest today. These are sort of the pillars of lifestyle medicine. It's healthful eating, making sure we're eating plenty of plants. We're going to talk about that. Increasing physical activity, managing stress, avoiding risky substances. That's things like alcohol and tobacco. Improving sleep and forming and maintaining relationships, or said differently, eat more plants, keep moving, sleep well, be present, stay calm, and love people. Some of you are probably familiar with this concept of the Blue Zones Power 9, but for those of you who are not, there are 5 places in the world that were identified as blue zones. Those are places where there are an unusually high number of thriving centenarians. So 100-year-old people who are living well. And they are in Okinawa, Japan, as you can see out here, Ikaria, Greece, Sardinia, Nicoya Peninsula, Costa Rica, and actually one in the United States in Loma Linda, California, which surprised me, but in retrospect, it does not. So I want to dive into those a little bit more deeply. The first one, and this is in no particular order, is move naturally. There are exercise guidelines put out by the American College of Sports Medicine, and they really say to focus on three things. First is we should be shooting for 150 minutes of moderate intensity aerobic activity a week. For people who aren't exercising at all, that sounds like a lot, but don't be scared of this. It is usually broken down as 30 minutes, 5 days a week. It can occur in increments as short as 10 minutes. So 10, 10, 10 is the same as 30. And I keep it really simple. We can talk about lactic acid levels. We can talk about RPE scales. There's lots of ways you can measure intensity of exercise. I use simply the talk test. So low level activity, you can both talk and sing. Moderate level activity, which is what we're shooting for, we could have a conversation, but I don't have enough breath to sing. High intensity interval training or high intensity aerobic activity, I'm just trying to breathe. So you can't talk or sing. And muscle strengthening, resistance training at least 2 days a week, preferably 3. Really, that's going to prevent frailty and falls in that marginal decade, in that last decade. And the one that is not represented on this slide is flexibility and balance. And that's important too, again, to reduce the risk of falls. So if you look at, this is hazard ratio of mortality on the vertical axis and leisure time physical activity on the horizontal axis. If you take somebody who is not moving, sedentary, and you have them exercise 2.5 hours a week, 150 minutes a week, you reduce all-cause mortality, so death by any cause, by about 20%. There is no additional level of activity that is not associated with additional risk reduction, but you get your most bang for your buck here, moving from not moving to 150 minutes a week. Anything more is better, but optional. And what's good for your body is good for your brain. You know, your brain is producing all sorts of hormones and chemicals, neurotransmitters, endorphins, norepinephrine, BDNF, serotonin, dopamine, the runner's high that we've all heard about or maybe even experienced. So what's good for your body is good for your brain, and it doesn't matter what kind of activity you do. The best activity for you is the one that you'll do, because if it's not fun and it's heavy, it's hard, you're not going to do it. There's plenty of data. I didn't want to overwhelm you with studies, but I do want to show you that there are plenty of data that support this idea that aerobic activity is good for your brain. There was a 2010 meta-analysis of 34,000 people that showed it reduced the risk of cognitive decline by 38%, high intensity, and moderate intensity by 35%, which is good news for those of us who can no longer or wish no longer to do high intensity interval training. It's as good as or better than any medication out there. Almost 700 patients in Lisbon, a 40% reduction in Alzheimer's. My mother died of Alzheimer's at 76, so I pay attention to these sort of studies. Next, plant slant. So we talked about George's experience, and plant-based eating is not for everyone, but I want to talk a little bit about this. I love this quote. It's really not by Hippocrates. It's widely attributed to Hippocrates, but we can find no evidence that he ever said this. Let food be thy medicine and medicine be thy food. This, by the way, is a photo of one of my patients, post-op day 1. You can barely see his sternotomy dressing sticking out over his pillow. And I took a picture of his breakfast, traditional sort of Southern breakfast, really. Eggs, sausage, potatoes, some cantaloupe over here, some milk, and this is a fiber supplement so you can have a bowel movement after anesthesia. And he told me, hey, doc, I think we're working on repeat business. I said, you mind if I take a picture? I'll cut your face out. So Dr. Katz was the director of the lifestyle medicine, American College of Lifestyle Medicine And I asked him if I could use this slide. He's fond of saying that there are three master levers of destiny: our fingers, whether or not we're holding a cigarette in them; our feet, whether or not we are using them to propel us through our world or have them elevated on the ottoman with the remote control in hand; and our forks, literally what's on the end of our forks as we insert them into our mouths. And if you're not keeping up with the nutritional information out there, it's overwhelming. And when you walk into somewhere like Barnes or Noble, you're just overwhelmed with all these different things that we should be doing. You don't eat plants, butter's back, Time Magazine, eat butter, scientists labeled fat the enemy, why they were wrong. And it's overwhelming. And I think a lot of us just want to throw up our hands and say, I'm just going to do whatever I want because no one seems to know what I should be eating. And that is really not really the case. This is from the United States Department of Agriculture. This is data that is pretty recent. This is around 2020. About 51% of our food comes from refined and processed foods, 42% of our calories from dairy and animal foods, and only 7% from fruits and vegetables. Sometimes that number is reported as 9%. I looked into that. It's 9% if you include French fries as a vegetable. No kidding. So 7% if you exclude French fries. You do not need to be a dietitian to recognize that this does not end well. Okay, this is a diet that is really ideal for chronic disease over decades. I really think this is probably the best advice on eating that I've ever seen. It is succinct, it is to the point, and it is not from a doctor. Many of you are probably familiar with Michael Pollan's work. I love that guy. I think he's incredibly curious. He's gone from nutrition to psychedelics research. There's nothing that does not interest Michael Pollan. I love eat food, not too much, mostly plants. Eat food, eat real food, eat whole food, eat food that's grown, eat food that your great-great-great-grandparents would recognize as food. Doritos, your great-great-great-grandmother would not know what that is. An apple, she's going to recognize. Not too much, this Japanese concept of hara-hachi-bu, which means eat until you're 80% full, which is they say it before meals to remind themselves to focus and eat mindfully. And I'll be honest, this is probably where I fall down the most. And then mostly plants. In the blue zones, about 90% of calories were coming from plant-based sources. So they were eating meat, generally 4 ounces of meat on average about twice a week. 80% rule, I've already mentioned, hara-hachi-bu. Friends at 5. So some of you who were paying attention may have noticed that on that first slide with the blue zones, it says wine at 5. We did find that wine was consumed fairly regularly in these blue zones and not to excess. On average, men were drinking about 1.5, the equivalent of 1.5 drinks per day. Women were drinking about 1 per day. It is certainly the case, and if you've kept up with Vivek Murthy, the Surgeon General of the United States, recommending that we consider putting warning labels on alcohol, which is not received well at all by the alcohol industry. It is true that about 7, maybe 8 cancers are increased by alcohol consumption, and that would include breast cancer, colon cancer, mostly digestive tract cancers. But I do believe that alcohol can be consumed in moderation. The current guidelines say no more than 2 a day for men, no more than 1 a day for women. That's because women produce less of an enzyme called alcohol dehydrogenase, which metabolizes the alcohol. But wine at 5 is becoming friends at 5 in part because of that association with cancer, and in part because we want to spread this message in schools. And wine at 5 doesn't go over well in schools, except for maybe with the teachers. Know your purpose. I think this is a big one. You know, I had struggled with this a little bit as I was trying to transition from cardiology to lifestyle medicine, and really honestly failed at 2 lifestyle medicine attempts. The second one was pretty painful. I left my job as the chief medical officer for Love Life about 1.5 years ago, and the best way to explain it is that I came to the realization it wasn't mine to do. It wasn't my purpose. And then it was sort of a crisis of purpose, trying to figure out, what am I supposed to be doing? And happy to share this later offline with anybody who's interested in how that transition occurred. But I know that I'm in the right spot now. Purpose in the Blue Zones adds about 7 years of meaningful, high quality life for people. And again, I come back to a Japanese term, this term that some of you have probably heard called ikigai, which means a reason for being. And this is sort of a westernized version of ikigai, but it is the intersection of what you love, what the world needs, what you can be paid for, and what you're good at. And I really like this quote. I collect quotes, and this is the first one that I collected about 5 years ago. Don't ask what the world needs. Ask what makes you come alive and go do it, because what the world needs is people who come alive. And if you take that to heart and you cross out what the world needs and what you can be paid for, and if we're really just going to focus on the intersection of what you love and what you're good at, that's your passion. If you can tap into your passion, you're living with purpose. Follow the energy of that. I knew for sure that the energy of cardiology was not what I was supposed to be doing anymore. I knew for sure that the energy, this is the best I've ever felt energy, was what I needed to be with on a daily basis. And so that's what led to that leaving. Downshift. Downshift is a big one. We need some way to shed stress, particularly in today's chaotic society. Political situations challenging for everyone, most people. Everything's a mess. I mean, Asheville's had floods, we've had hurricanes, we've had forest fires. There's just a lot going on in the world right now that seems challenging, and we've got to have a regular practice of downshifting. For me, that's been over the last 5 years. I've become very interested in meditation. That's been something that works well for me. I'd say exercise is probably a double duty stress reliever. It's exercise and great for stress relief. But you just have to have a practice that helps you deal with this. And I wanted to introduce this concept some of you may not be familiar with, called eustress. All stress is not bad. And it's really not stress. Stress happens. It could be good or bad. Strain is what we really should be focusing on, which is when a stress is applied to an organism, in this case, a human being, how do we incorporate that stress? Do we use it for production, or do we continually elevate cortisol, which is not what we want to be doing? This book is interesting for some of you who are interested in this sort of concept. Mihaly Csikszentmihalyi, who's a Hungarian psychologist. And I like this simple idea that if we have really not enough skill for the challenge, we're here in this anxiety zone. If we have a lot of skill and are not challenging ourselves, we're bored. And what we really want to be is in this flow channel where the skill and the challenge are really lined up very nicely. The problem today, as I said, is that the lion is not our stressor. I mean, the stressor is climate change, emails, traffic jams, constant texting, screen, blue light at night. The list goes on, which keeps us from ever turning our cortisol levels down. Cortisol is a stress hormone. It's not the only one, but it's one that I think most people are familiar with. And when you have cortisol on all the time and it's not ever cyclic, then it creates a lot of problems. It impairs cognitive performance. It dampens our thyroid function. It messes up our blood sugar. It disrupts our sleep. It really does all kinds of things that we don't want to have done and contributes to chronic disease. And even for those super experienced meditators, at times, I think that the stress of modern society just overwhelms us, and we all have moments where we didn't react well to stress. And I think we need to cut ourselves a little bit of slack when that happens. I enjoyed meditation. I am practicing transcendental meditation. Happy to chat about that with anybody who's interested. But it can be anything: yoga, music, walking, whatever it is, you do you. But find a way that you have to practice this on a regular basis. Belong. The next three, belong, family, right tribe, all speak to this social connection piece, which I think is the most interesting piece. One of my mentors some years ago said, it was in med school actually, said the only thing that will matter to you at the end of your life is who you loved and who loved you. And it was one of those moments where I said, yes, that is right. And if that's right at the end of our lives, why are we not focusing on that as we live our lives? And so I love that in the blue zones, we found that to be the case. Belong in the blue zone specifically was referring to belonging to a faith-based organization. It does not need to be a faith-based organization. You just have to belong to something that's bigger than yourself. It could be church, it could be a poker group, it can be whatever it needs to be. But that added 14 years of life on average to individuals in these blue zones. Family first. These patients or these people had prioritized their family. They generally lived in multi-generational homes or next door to family members that were older. The grandparents are helping raise the grandchildren. Just a lot more bound, a lot more tie to the family than what we see sometimes in Western culture. And then right tribe, another Japanese word called moai, M-O-A-I. In Japan, when you're born, you have an arranged friend group. There are 4 or 5 same age kids that are put in a group, and you're raised with that as your inner circle. So as you age, they're at your weddings, they're at your every event, they're at the birth of your children, they're at your funeral. I mean, these are your best friends in life. And I think we all would benefit from thinking about who are those people? Who are those people? Do I have those people? It is not the number of relationships, it was the quality of relationships. Who am I going to call when I'm really in trouble? And I want to share my experience with this Ornish lifestyle medicine program. When I became interested in lifestyle medicine, we brought to Mission Hospital in Asheville in 2016 the first intensive cardiovascular rehab program in the country, or in the state rather. And it was this Ornish reversal program named after Dean Ornish, who's a family practice doc in Sausalito, California. And it was lifestyle medicine in action. It's all the things we've been talking about in a programmatic structure. It was a deep dive for patients. Patients came and were with us for 4 hours, twice a week for 9 weeks. So a total of 18 4-hour sessions, 72 hours. Billable by insurance, they could be self-pay, private insurance, Medicare, Medicaid, everything. All of it was covered. We spent an hour every day feeding them and talking about nutrition. We spent an hour in exercise. We spent an hour in stress management, which was hatha yoga and meditation. And as the medical director of that program, I could participate in all of those things. I felt like I knew the data around nutrition. I read most of the studies. I felt pretty comfortable with the exercise data. I knew that I personally needed the stress management piece myself. That's when I got into meditation, total game changer. As the medical director, I could not be part of the community support piece. In community support, this was a cohort-based program, so we had 12 people come in together, and they graduated together. They went through the whole 72 hours together, and many of them are still friends today. They met with a licensed professional counselor or a licensed clinical social worker, and they talked about, from what I heard, because again, I wasn't part of this experience, it was very authentic sharing, very vulnerable sharing. There's a lot that comes up for patients when they've had sudden cardiac death and have been resuscitated. There's a lot that comes up for people, especially heart transplant patients, when my heart was someone else's heart previously. It's a big deal for people emotionally. And so I was really surprised, in retrospect, probably I shouldn't have been surprised, that when we did exit interviews with these patients and we asked them which of the 4 components of this program were the most impactful to them, 94% of people said it was the group support piece that was the most impactful. It is what allowed them to then be in a state of mind and body to engage in these other pillars. I will always remember that as I think about what I'm going to do next. So Ornish coined this term cardiovascular disease reversal. That was a new term. This was 1990. Basically what he did is he took a bunch of people who had had diagnostic angiography or heart cath, and on average, they had about a 40% blockage in their heart arteries. And he divided them in two groups. One group got optimal medical therapy. So aspirin, statins, beta blockers, ACE inhibitors. I'm sure that a number of people on the call are on some of those medications or maybe all of those medications. And the other group had no medications and went through his program. It was plant-based nutrition, exercise, yoga, meditation, group support, all of those pillars of lifestyle medicine. At 1 year, they all had another heart cath, and at 5 years, they all had a third heart cath. The Ornish group had almost 8% less cholesterol buildup in their arteries, although they were on no medications. The medical therapy group had about 28% more cholesterol buildup in their arteries, despite the fact that they were on, quote, all the right stuff. That is interesting to me. As a clinical cardiologist, I really don't care so much how much cholesterol buildup you have in your arteries. I care if you have symptoms related to that, and I care if your life is cut short from that. So when we look at clinical endpoints, we find that 91% of people in the Ornish group had, like George, relief or decrease in their angina. In the optimal medical therapy group on anti-anginals, there was a 165% increase in angina. In the Ornish group, they were 2.5 times less likely to have a heart attack, stroke, bypass surgery, stent, or cardiovascular death than the medical therapy group. Interesting. As a lipidologist at the time, I didn't recertify in lipidology because it was just incredibly boring to me. 20% LDL reduction in both groups, despite the fact that 60% of patients in the medical therapy group were on statin. None of the patients in the Ornish group were on statins. So it was not only as effective as optimal medical therapy, it was better than optimal medical therapy. 99% of patients stopped or reversed their coronary heart disease, their cholesterol buildup in their arteries, with an average of about a 300% increase in their blood flow on stress testing. 300% increase. These are some of the outcomes that we got. This was the last, when Mission was bought by HCA, we transitioned from the Ornish program to the Pritikin program. It's a great program, but it's not a reversal program. It's a Mediterranean diet. It's easier, frankly, for patients to adhere to, but it doesn't quite get these sort of results. We saw weight loss of 5%, cholesterol improved, blood pressure improved, diabetes improved, depression score was cut in half, exercise capacity was increased by 50%. This is changing health span. This is rearranging that marginal decade. So in summary, I think that the current treatments for chronic disease are just too limited. They really don't address the root cause of the disease. It's a Band-Aid approach, and the root cause of our chronic diseases are lifestyle habits, and patients need to know that. You need to know that. We all need to know that. You have more power over your chronic diseases, prevention, treatment, and potentially even reversing them than maybe you're aware of. I love this quote, again, by Maya Angelou. We've done the best we could until we knew better. But now we know better, and we need to do better. And it's going to be very difficult to change this medical paradigm because for all the reasons. I'm not completely cynical about it. I know that this is a capitalist country. It's just, it's hard when there's so many vested interests that are going to be wanting to keep it as is. And then true thriving. I mean, if we really want to not just survive, but thrive, we really need to integrate all those aspects of health, physical, mental, emotional, and spiritual health. So with that, and I apologize for the early problems with the tech. Let me see what kind of questions we might have. Yes, I'm happy to share all the slides with anybody who's interested. I've read that some medical studies support a recommendation of drinking a moderate amount of red wine lowers overall mortality rates, especially from cardiovascular disease. Is that reliable? It does seem that in those countries, it's very difficult to get to do nutritional studies. And it's partly really difficult because you can't really control what people are eating. Even when you think you've prescribed a diet for them, the truth is that people have a really hard time staying on a particular diet. So nutritional studies are challenging. Most of what we've gotten from nutritional studies is observational data. We look at what people are doing and we get health questionnaires, we get food frequency questionnaires, we ask them how they're living, and we collect all this data. In countries where they are drinking a moderate amount of red wine regularly, they do seem to have lower mortality rates. They do seem to have lower rates of mortality from cardiovascular diseases. Is it the alcohol? Is it they're eating more plants? Is it they're eating less saturated fat from the animal products? Is it that they are moving more regularly and getting more steps per day? It's very hard to tease all that out. I think that the best advice I can give you today is I would never recommend to someone who doesn't drink that they drink for their health. Never. I would tell someone who does drink, and I do drink, that pick your battles. There's no question to me, I wear an Oura ring. I learned that if I have a drink within 2 hours of my bedtime, it's going to raise my resting heart rate at night by about 5 beats per minute. It is going to drastically reduce my deep sleep, which is when we do a lot of physical repair. So I like the way Peter Attia handles this. I pick my battles. When somebody is, I don't drink alone. When somebody is with me and I have friends or family over, I might have a glass of wine. I might have two, but I know how it's going to affect me, and I'm more aware of that choice. Sorry, that's kind of a long answer, Jerry. Western style medicine seems more reactive, reacting to problems after they're diagnosed. Should it be more proactive, trying to head off problems? Absolutely, yes. We are incredibly reactive, and that's part of the reason that we have such an expensive healthcare system. We spend tons of money after the disease has already occurred. And I think it was Ben Franklin, wasn't it Ben Franklin? An ounce of prevention is worth a pound of cure. Yes, 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 all day long, yes. It is far easier to prevent the disease than it is to reverse it. It is far less costly to prevent the disease than it is to reverse it. So I think our Western style allopathic model is struggling. What's your opinion about estrogen replacement? Great question for menopausal women with a family history of severe heart disease. That is a conversation that you really need to have with your prescribing physician. Estrogen, it certainly alleviates menopausal symptoms. Unopposed estrogen is problematic. We want to, if you're going to replace estrogen, we really want to think about estrogen plus progesterone, unless you have no uterus and ovaries. But that is it was something that we were fearful of doing for a long time, based on a couple of studies that, in retrospect, were probably not perfect studies. And I think that today, I would say most of us would say estrogen replacement is, particularly if you're struggling with symptoms, is okay, but there are some subtleties there. Curious about statins, seem to be frequently prescribed. Yeah. I hated it. Andy, I'm with you. So yeah, so statins get a really bad rap. I don't think they're really any worse than any other medication, but they seem to be the ones that are associated with some significant symptoms. Muscle symptoms, muscle pain or weakness is really the problem with statins. I think about statins in two ways. There are two populations. There's primary prevention and there's secondary prevention. For secondary prevention, meaning you've already had a cardiovascular event, you've already had a stent, you've already had a bypass, you've already had a stroke, we know you have vascular disease. I think that I am much more likely to treat you aggressively and put you on a statin. For no vascular disease, in this case, patient had mitral valve repair, but no vascular disease, and this was for primary prevention. to prevent that first event, I think the bar is much higher for me to start a statin. The number needed to treat to prevent one event in someone like that is about 1 in 80. And I'm just not sure that it's worth it, frankly. I would have a conversation. I think there are a couple of risk calculators online that I would direct you to. One is the ACC cardiovascular risk calculator. The other is the MESA, MESA, Multi-Ethnic Study of Atherosclerosis, MESA study, and you can plug in all your variables: age, cholesterol, blood pressure, all the smoking history, family history of cardiovascular disease, everything that a doctor would be asking you and trying to help make this decision. And it spits out a percentage risk of your having a cardiac event in the next 10 years. That conversation, that number really is interesting in having that conversation. I would also consider doing something called a coronary artery calcium score in primary prevention if we're trying to decide, should we put this patient on a statin or not? Coronary artery calcium score is about a $50 CAT scan. You need a prescription for it in the United States. It is inexpensive, generally not covered by insurance, but it's cheap. You don't have to have an IV. You don't have to have contrast. You walk in street clothes, you lie down 5 minutes, and you're out the door. What it's looking at is calcium buildup in your heart arteries. If you have cholesterol buildup, it will become calcified. So therefore, the calcium is a marker of cholesterol, is a marker of risk. If your calcium score is elevated, particularly if it's significantly elevated, it suggests to us that you have more asymptomatic or subclinical cholesterol buildup in your arteries than we thought. And in that patient, I would have a conversation about dietary change. I would have a conversation about the possibility of adding a statin, depending on the situation, the numbers. But a coronary calcium score is a useful test. Comment on long-term use of statins, risk of long-term use of statins, risk to liver brain function. Starting cholesterol, an important focus in lifestyle medicine. Yes, I think we've addressed some of that. Cholesterol is sort of the sine qua non of cardiovascular disease. What happens with a heart attack is you have cholesterol buildup. The cholesterol becomes inflamed. That inflamed cholesterol basically cracks open and is exposed to the circulating blood, and the circulating blood forms a blood clot on the top of that ruptured plaque, and it's the blood clot that acutely chokes off the blood supply to the heart muscle downstream, which then causes an abnormal heart rhythm that is fatal. And in fact, the most common presenting symptom of symptomatic cardiovascular disease in the United States is sudden death, which is falling over dead. So we do use statins. The lower your cholesterol, the better. It also requires inflammation, and all the studies we have with statins were on patients who were using or eating rather standard American diet. So it's really interesting if we do inflammatory markers on patients. This has not been done. There's no study here. But if we do inflammatory markers on someone eating an anti-inflammatory diet, so a healthy Mediterranean diet, a plant-based diet, lots of fruits and vegetables, beans, nuts, seeds, legumes, whole grains. If their inflammatory markers are low, and they are in almost every circumstance when they're eating that sort of diet, does the cholesterol really matter as much? I don't know the answer to that. It's a topic of a lot of debate, but we certainly know that long-term use of statins in some patients are going to cause muscle symptoms, particularly in older, low body weight females who have low thyroid levels. The only case of severe statin myopathy for which the patient was hospitalized that I ever took care of was an 84-year-old woman with low body weight who had hypothyroidism, and she ended up with statin myopathy and died. So enough about that. Information on how to begin transcendental meditation. There are a number of transcendental meditation centers around the country. If you go online and just Google Transcendental Meditation Training Center, you'll find one near you. Please do that, and then I'll share my contact information. I'd love to hear about your experience. Number needed to treat for the Ornish study. I don't know the answer to that. I've never calculated the number needed to treat. I think it was such a dramatic difference that I think the number needed to treat was quite low. I mean, I would think it would be in the single digits. Reversal of heart disease by the presence of an ApoE4 gene. There are 3 flavors of the ApoE gene. We all have them. There's APO234, and you can be a 2-2, a 2-3, a 2-4, a 3-4, a 3-3, or a 4-4. I'm a 3-3. I had mine checked when my mother died of Alzheimer's, which is about 60% of us are 3-3. ApoE4, 1 copy increases your risk of Alzheimer's by about 2-fold. If you're homozygous, so ApoE44, it's about at least 10 and maybe 15-fold. Is reversal of heart disease made more difficult by the presence of an ApoE4 gene? It is not clear the answer to that question. The short answer is probably not, based on the information that we have. I am not in practice locally. I'm working on a couple of projects. One is a lifestyle medicine 6-week digital program that I want to share to help people make some of these changes. And the other is I'm seeing patients who were referred in Asheville to see a cardiologist who are uninsured. And it's just my way of giving back to the community. Especially when you don't speak English as a first language, trying to navigate our system is problematic, and they need help. And so I'm going to talk with all the patients who are here referred to see a cardiologist and help them navigate the system. I am very happy if anyone on the call tonight wants to connect. Judith will share my contact information. Happy to share my cell phone, my email. Text me, call me, email me, whatever works for you. Happy to help you one-on-one. Happy to reconnect and talk about college. Happy to do anything, but particularly happy to help you honestly with any medical, any situation that I can. No cost. I enjoy it, and I'm just doing it because it's fun. Some say it's not the Mediterranean diet, but rather fasting that leads to health benefits. Thoughts on fasting? Very interesting. So there's multiple ways to fast. Fasting for me means you haven't eaten 24 hours. Sometimes when we talk about fasting, what we're talking about is time-restricted eating, which is eating our calories not over, we're all going to hopefully not eat while we're sleeping, but that may be only 8 hours or so. Time-restricted eating means that we're eating our calories in at least a 12-hour window, and for most people, it's an 8-hour window, and then fasting for the other 16 hours. True fasting means I haven't eaten in 24 hours. So if you really, the short answer to this question is the Mediterranean diet works. It doesn't have anything to do with fasting. Fasting does have some potential benefits. You probably, if you are fasting or doing time-restricted eating, are going to lose 1 to 3% of your total body weight. There may be some benefit in cognition. People who have taken many mental status exams who are fasting tend to do better on cognitive tests, particularly executive function, multitasking. So there are potentially some benefits. If you're interested in this, I would direct you to the work being done by Dr. Walter Longo, L-O-N-G-O, who is the director of the Southern California Center for Longevity. Maybe one more question. It's almost 8:30. Let me see. Certified organic grass-fed beef, is it as bad as other beef? No. Definitely has a different omega-3 fatty acid profile. I think part of our problem with our food system in the United States is feedlot beef, antibiotics, and if you're eating grass-fed beef, you're doing much better. If you're eating, venison and that sort of thing, you're doing much better. Can you incorporate that in your diet? It depends on some of your other risk factors. One more. Good question, Tom. Good, Ramon. The wearables versus, is it potential information overload? I wear Anura, and I find it interesting. Part of me wants to I don't really need a ring to tell me how I slept. I can tell you in the morning if I slept well or not. Yeah, I mean, I think it's kind of like ordering a medical test. What am I going to do with the data? So if you cannot obsess about the data, and you're interested and you learn something from it, as I did, cut back the alcohol, don't drink, and don't have a glass of wine with every meal or every dinner, not drinking for breakfast. If you can use it to make those kind of changes, I think it's useful. If you're going to obsess about it and I thought I was energetic, but my ring tells me I didn't sleep well, so I'm going to have a terrible day. That's not very helpful. So there are a bunch of great questions on here. Maybe Judith, if you or someone could share those questions with me, I would be happy to take a shot at answering them and maybe sharing some of those with the group at large by email or whatever might work for people. So thank you guys for your attention.
Well, Brian, thank you so much for taking the time to put all this amazing information together and sharing it with us tonight. I don't know if you were seeing, I was trying to answer some of the questions in the Q&A, but a lot of folks were asking, I know we got one or two, but several wanted to.
I can't hear you anymore, Judith.
Yep, I was just noticing that.
Okay.
Sorry. We will absolutely be sharing Brian's information out tomorrow in a follow-up email. We will be sharing his slides and contact information. And Brian, yes, we had a lot of thanks to those of you who put the questions in the chat. We will try to capture those and see. Brian, you'll have a lot of reaching out to do.
Good, fun.
We're so glad that folks found the topic interesting and decided to join in tonight. We also did record this program this evening with Brian's permission, and it'll be on the college's YouTube channel. We'll include that link also with the follow-up email we'll be sending. But if you go, generally speaking, to our back to school class website on the college website, that's where all of the classes have been, all the recordings are being housed. So please know that that'll give us about 24 hours or so, and that'll be there. We are, again, grateful for Brian and all of his wonderful information and willingness to be a part of this program tonight. And we also appreciate all of you dialing in and hope that you enjoy the rest of your evening. Thanks, everyone.
Thank you, guys. Be in touch.